The retina can handle it pretty well, usually the sclera as well, but not like that with the choroid, the Bruch's membrane, or the RP. Now, going along with the general anatomy of the retina, we have the different layers and how you perceive it in the OCT, but more than that, I would like to go into this next schematic in which you see how the RP and the Bruch's membrane comes apart, allowing the neovascular tissue to emerge as a consequence of the difference between the oxygenation of the retina and the choroid. There are, of course, predispositions for this. Not everyone that gets a strong enough punch in the eye gets this type of complication. Degenerative myopia can cause this. A long history of central serous retinopathy can weaken the Bruch's membrane and cause predisposition to develop this kind of complication. And of course, the presence of angiostrix in all the different pre-existing conditions can also be a factor in this. This is a case I received a while ago back in my medical office, in which an acute subretinal hemorrhage as well as the exudation and rupture of the choroid was present, and afterwards the evolution came like this. Now, if you look at the pre and post, you'll see that the preconditions for the development of this neovascular membrane were at first glance. So what I want you to take into account in this type of cases is not that there's a lot that you can do once the trauma has already been done, but there's a lot that you can do if you do a correct follow-up of the patient and be ready to administer the proper treatment as soon as the first glances of CNVM starts to appear. In this next picture that Dr. Madeleine has kindly provided for me, you can see pretty much the whole chronology from the very acute to the late onset of CNVM and the concurrent exudations. Now, regarding the diagnostics, of course, fluorescent angiography is the best tool we have available for proper visualization, especially from differentiating the ones that are actively exudating some fluid from those that are pretty much dormant. You can also use andesine green, but I much prefer fluorescent angiography for the quality of the image. And right now, you can also use OCT and OCT angio. Being OCT angio, the less we don't have that much information yet and that much experience as we have with fluorescent angiography, so I think it will still be a couple of years, if not decades, before the fluorescent angiography loses all of its use in this kind of patients. Now, regarding the prognosis, I'm going a little bit with the literature here. You can see that pretty much from the presence of peripheral choroidal ruptures is almost the most frequent presentation in this, while 22% usually come in the posterior pole with the macula, and only 8% of those end up developing CNV. Now, that, though it might seem a low percentage, is very important because those are the patients that we can actually do something about other than just following them up. Usually, retinal detachment is not present, but if it is present, the prognosis goes down considerably. And of course, foveal location, multiple ruptures, and poor baseline visual acuity are associated with failure to record with driving vision. This is important because the conditions that you found at the beginning of the trauma are the more likely to determine the result afterwards, even if you do whatever the best conduct is possible. So going back, the prognosis will depend on location, on the baseline of visual acuity, and associated pathologies. And of course, the early treatment of retinal detachment as well as choroidal neovascularization will make the biggest difference that we as physicians can act upon in this type of patients. Now, regarding the treatment, what to do? Of course, anti-angiogenics are the best tool, while there have not been any major studies to put them on label for these drugs. We all know that they work. The use of photodynamic therapy may have been a possible tool in the past, but right now with the possibility of using anti-angiogenics, I think it has fallen off from grace. And of course, if there are any other things that we might need to take into account, like a retinal detachment or something else, vitrectomy is always present. Now, for the future, this might be a possible solution. This is a paper published earlier this year with the use of cultured RPE cells placed directly behind the retina, covering the CNVM in patients that had been legally blind for a very long time. And over a 1-year follow-up, they have developed a very good or an increase in their visual acuity without any major complications other than the one below reintervention for a slight retinal detachment. But in those cases where there's nothing that could be done, now there seems to be an alternative. These are the references to what I just said, and thank you very much for your invitation. It's been a really, really long week here, and I really appreciate your attention. Thank you.